So the new paradigm, we're going to talk about the approach of what that means, and we're going to go through, as Mario said, some of the basics of addiction, some of the circuitry, and go from there. So I am the Chief Medical Officer at Ascension Brighton Center for Recovery, and am responsible for really development and some of the clinical direction of that center. I do write questions for the American Board of Addiction Medicine Foundation for maintenance of certification for physicians in addiction training, and that translates into I'm a geek, and I read a lot. And I don't have any other financial obligations or any other disclosures of any kind of relevance. So again, our objectives in our time together is really thinking about what it means, addiction and the disease concept of addiction, then really understanding how the brain works as far as specific to addiction, and then look at how the brain heals. And this is a struggle for, I think, a lot of people to say, does it heal, does it not heal, et cetera, and we're going to go through that. And then understanding how this new treatment model, known as the new paradigm, actually applies in applying these scientific principles into actual clinical treatment. So the regions of the brain that are actually impacted by addiction, we actually have a lot of knowledge of where those places are, what circuits are involved, what actual neurochemicals are involved, and I just want to walk through that here for a minute. So one of the major places that is impacted is the frontal lobe, both the frontal cortex and the prefrontal cortex, and that involves issues of planning, judgment, and decision making. Some of the further in circuitry, such as the nucleus accumbens, the medial forebrain bundle, and ventral tegmental area, areas of the brain really tree down to reward. And finally, the amygdala, another part of the brain, deals with emotions and how somebody is conditioned to respond in an emotional fashion to certain stimuli. And so what we see, though, and this is from the American Society of Addiction Medicine, I frequently just read the definition so that when we're communicating, I find a lot of times in addiction as a discipline, a lot of the terms, a lot of the things that are said, we say the terms, but we may not say or be meaning the same thing. So I sometimes start with just terminology so that kind of level setting so that we're all saying the same thing. So in that, addiction is a primary chronic disease of brain reward, motivation, memory, and the related circuitry that we were just looking at. Dysfunctions in those circuits leads to some characteristic biological, psychological, social, and spiritual manifestations. And this is reflected in an individual pathologically pursuing reward and or relief by substance use and other behaviors. So addiction is characterized with a character or nature of it is the inability to consistently abstain, impairment in behavioral control, craving, and that's a big, that I'm just making a note of that. Craving is very much so an addiction phenomenon. Diminished recognition of significant problems with one's behaviors and interpersonal relationships, and a dysfunctional emotional response. Like other chronic diseases, addiction often involves cycles of relapse and remission, and without treatment or engagement in recovery activities, addiction is progressive and can lead to disability or premature death. So while that is a comprehensive definition, I think that is a good definition of how complex this disease is, even though it starts as a primary chronic brain disease. So let's then start thinking together about what this means and what this kind of our understanding is of the circuitry and really what is going on in the brain. So it's a cycle. And that cycle of behavior that people see characteristically, again, trees back down to the actual brain and its functions, but there is a use or binge or intoxication that's mediated by the basal ganglia. And then after that, the person will go into a negative emotional state and or withdrawal, and that is mediated by that amygdala or extended amygdala we were talking about, and then goes into kind of preoccupation and or anticipation, you could say craving as well, that's mediated there in the prefrontal cortex. And this is that cycle that we see clinically, that loved ones see, that someone may be experiencing themselves, of use, withdrawal, and negative affect, and then thinking about it, preoccupation, and that's the cycle. So in that binge intoxication stage of the disease, the main issue is, the fancy word is salience, but a lot of it, or more than usual. A higher amount of dopamine release, a higher incentive that's there, and that's mediated by the basal ganglia, and that is through the neuropeptides of dopamine and opioids. Now, that's why sometimes a loved one will be on something like naltrexone, if somebody has had a loved one or personally used that. It blocks the opioid peptides, which then reduces the dopamine, which then reduces that reward and or craving that the individual experiences. The next part of this then is withdrawal, and withdrawal is a deficit of reward and stress surfeit, or a lot of stress, a ton of stress, more stress than usual. And that is that interpretation of that amygdala, and again, norepinephrine, corticotropin releasing factor, and dynorphins are all related to that. And finally, that third part of the cycle, again, is that preoccupation and anticipation. And the main issue there, again, is executive function, that judgment or decision-making. That prefrontal cortex and glutamate and GABA are the two main particles. Now, this is detailed, and I know, but to understand, again, where I'm going to go in the later part of the presentation, I think it's important to start with some of these really basic things on the science side. And so you see, again, this cycle. Binge intoxication, and then withdrawal, and then craving, and that's where the chemistry, so we know the parts of the brain, we know the neurochemicals that are doing this, we know a lot of these, and that's what's driving this cycle. And so then there's a difference then if somebody uses one time versus chronic use, in which case then you start to see, this is the control patient in this specific individual, and you can see whether cocaine, methamphetamines, alcohol, or heroin, you can see the brain starts to change in regards to dopamine in that reward center. So in chronic use, then you start to see chronic brain impairment, and then clinically, and really from the stories of people that are in the throes of addiction, is this sense that the brain has been hijacked, trapped. I don't want to do this. Why am I still, I don't want to. There is this hijacking that then occurs through time. So addiction then is a chronic disease that affects multiple parts of the brain. The cycle that is so familiar, again, is the intoxication, then an affective change and withdrawal, and then preoccupation and anticipation. But we also know from other parts of the science world that the brain also can change. And the brain also has capacity to heal. So then you have a couple of questions then to say, so this is an illustration, and I'm just now asking you then, so is this how the disease of addiction is viewed? And you can get a sense that the brain is fragile, which it is, and this is kind of looks like paper, and it looks like, pieces of it are flaking off, and is the brain permanently damaged and destroyed, or can it heal? So this comes down to some other things to think about. So the first question is, well, first, do you believe that the brain can heal? That's an important question. The second is, should relapse always be the expected outcome, even though that was part of that initial definition that was spoken about? And then, can the brain of somebody with addiction truly heal? So this is a question that everyone in this room has to at least think about, wrestle with for a few minutes, and then let's see what some of the science and some of the data actually demonstrates about this. So when somebody comes to a center like Brighton and goes through the withdrawal phase, and this comes out of the alcohol literature. I will use some of the alcohol literature in this talk simply because we have the most information on this specific disorder compared to a lot of the other disorders. But in the brain science of it, 93% of people have a mild or major neurocognitive impairment measured on neuropsychiatric testing after detoxification. 93%. 71% in the same study still had the disorder after 10 days that's either mild to major neurocognitive disorder that's measurable by neuropsychiatric testing. Now, even there, this is it depends on, optimist, pessimist. Is this half empty or half full? You could say, wow, these are terrible rates. And it's true. I would personally say that for the payment systems of the world, by 10 days, 71% still having neuropsychiatric impairment shows that length of stay needs to be longer, probably for most people, than 10 days. And so you could say, wow, that's really still a high rate, but I'm going to flip it around. If you went from 93% impairment to 71% impairment in 10 days, what does that also tell you? That the brain in recovery starts to change. It starts to heal. So another study, after 6 weeks of recovery, you see that they were also be able to show and demonstrate that neuropsychiatric changes again started to show improvements. Now, they were statistically significant, that is, they were measurable and they could define that there was a difference after 6 weeks, but they weren't able, nor was the study designed to say, is that clinically relevant or is that going to change long-term outcomes? But again, the brain starts to heal. Now, this is a slide from a study looking at polysubstance use disorder, so severe, where people have multiple addictions that they are dealing with at the same time. Now, I know the font is small, so I'm going to have to just describe this for a second, but this is actually looking at executive function. So, and the specific test is the Global Executive Composite from a test called the BRIEF-A, which is looking at neuropsychiatric function. Now remember, in the original parts of what we were talking about, that one of the main places of the brain that is impaired is the prefrontal cortex and the frontal cortex on this concept of executive function. So the scores on this, how to read this, is that as the score goes higher, because it's a composite of 8 different domains, higher is worse, lower is better in this specific study. So the control is here, and you can kind of see that even by a test and retaking the test, if you had the same test done again, you probably are going to do a little bit better on it the second time than the first, so that's why controls are important. You see the control patients are here. The patient who started at the same place with impairment but remained abstinent for that year had a significant brain healing, Whereas the patient who was starting at the same place but continued to relapse in that year doesn't really heal. So you can see then, by a year, there are significant improvements. So that's, I think, very, very important to see. Remember that one of those three major domains we talked about, again, was the concept of high amounts of stress. So if you look at this was, again, looking at psychological distress and looking about what happens with somebody with polysubstance use disorder over the course of a year. And again, higher is worse, lower is better. You can see that the controls are basically pretty stable in their level of psychological distress. The person with polysubstance use disorder that remains abstinent sees more and more and more healing. The person that is relapsing sees some, but really doesn't fully improve yet again. And then some photos from NIDA. This is the brain region that you're talking about, that we were talking about with rewards. That's that basal ganglia. So the interpretation of this study, you could see that the red zones are normal dopamine function. After 1 month of abstinence in the brain of somebody who's using methamphetamines, not really much dopamine activity at all. And you can see, while not exactly back to normal, you can see much more normalized function in that zone after 14 months of abstinence. And then probably the longest term data that we have is in alcohol use disorder. And in that long-term data, so the median time in that was 6.7 years. And there was a range. There's people as low as 6 months and as long as 13 years where they did panels of neuropsych testing, again, to look at what the function of the brain is. And the person with alcohol use disorder had a brain that looked very similar to someone who'd never had alcohol use disorder at all in the control panels. So the only thing that was different was spatial processing that they could detect with that kind of testing over that period of time. So what this indicates is that brain healing occurs. We can't always say exactly what month or what time frame, but you can see that when you look at, like, broadly the literature, by, months of time, certainly, people, well, let's start again. At the beginning, almost everyone has cognitive impairment. By 6 weeks, they can detect some changes. Somewhere between 6 months and a year, you start to see substantial changes. And somewhere out into the course of years now, you start to see a brain that looks very similar from a functional standpoint to someone who doesn't have addiction at all. So, and it doesn't then come by surprise that if you look at the physician health program, what Mario was referring to with Dr. Merlot, and that model, that in that design, 5 years of treatment is really, very much so related to very good outcomes long term, because this is consistent with the brain healing science. So again, the addiction, brain, and detoxification, and the brain disease there after detoxification is very, very evident. And after 6 months, you see some healing that you can measure. By 12 months, substantial healing. And then by 5 years and beyond, it looks very similar to a brain that didn't have addiction previously. So I'm going to just throw this in. It's beyond the scope of what we can talk about in the entirety of our time here, but the role of nutrition in recovery. Because, and again, I would have to go to lateral studies, but in the science of brain healing, can you heal a brain if you're deficient in vitamins? Not very well. Can you have neurological problems from vitamin deficiencies? Absolutely you can. Do a lot of our patients have vitamin deficiencies when they come to us at Brighton in an inpatient kind of program? Absolutely. And so part of that, and part of, I think, the frontiers of where addiction medicine research needs to go is, are we optimizing some of these things? And if we do, how does that improve brain healing through time? Because again, I'm not so sure the brain is going to heal if the person's diet is Lucky Charms, pop, and pizza for the duration of that 5 years. So there's got to be some other things in a holistic approach to really help people in the brain healing side of the ledger to really fully heal. So then that leads us to then where we're at right now in the field of addiction. How many people think of the disease as chronic and can't heal? I think that's a problem. I think another problem is if the brain heals in time and recovery, especially once substances that impair that brain healing are gone, what is our relationship to putting substances that could impair that brain healing back into the system? That's a problem too. And then what is the commitment that we have in treatment for long-term change? And that affects everybody. That affects what individuals are seeking in treatment. That affects families. That affects treatment professionals. That affects everyone. And so we do need a paradigm shift. So that paradigm shift, the term new paradigm, was kind of originally coined by Dr. Bob DuPont, who is one of the first authors on a lot of papers related to the physician health program. So the new paradigm, generally speaking, again, is very much so related to how safety-sensitive professions actually treat someone with addiction. So that could include the physician health programs. Here in our state, that's the Health Professional Recovery Program, Lawyers and Judges Program, the Human Intervention Motivational Study Program, or HIMSS, which is for commercial airline pilots. I think all of us want to make sure that when we board a plane, our pilots are safe and stable. This is what a lot of sobriety courts will follow, elements of this model. And I would also say advanced addiction treatment facilities are also starting the process of really implementing some of the new paradigm treatment models at scale. So what are some of those principles? So encapsulating what a new paradigm would actually look like. Well, the first is that there has to be a change in how we view abstinence or how we view relapse. And why that's an important change is that you saw already the data that I presented. If someone is frequently relapsing, does that brain heal? The answer is no. It doesn't. We have measurements of this. It's not going to heal. So the design of a program has to be able to have somebody in a sustained course of treatment that is supportive but leads to abstinence for the purpose of brain healing. It has to be custom. It has to be patient-focused. It has to have accountability in the sense of frequent drug and alcohol testing. It has to use both management of relapses that have some. So I would say the word in the literature, the two words are consequences and leverage. I would use terms that are more treatment-friendly to say you have to make treatment changes that are meaningful, that have some meaning, and finally, involvement in 12-step recovery. So why do we have to change? So whenever you have this like concept of a paradigm shift, the first question is why? So you're saying things need to change. How come? Well, let's look at outcomes and then think about what these mean. So if you are abstinent at 5 years, and this is, kind of mimicking the data that Dr. Merlot presented just a few months ago, you have about an 86% chance of being into long-term sustained recovery, that is 10 years plus, if you have 5 years of continuous abstinence. Whereas about 14% of patients will still struggle with relapse. If you move down to 3 years, you have about a 66% chance of long-term recovery, again, 10 years plus, whereas about a third will go on to have relapses. If you go to 1 year, you have about 36% chance of long-term recovery. So you could see the data that was presented already that at 1 year, you're healing, but clearly not all the way there. And so you could see the 1-year data and the 3-year data are almost mirror images of each other, but now you're into a place where more people are in a relapse phase as opposed to in long-term recovery. Where do we stand nationally at this point in time in 2019? Well, many places will have somebody go inpatient, have some treatment in an inpatient kind of facility, generally transition out into some intensive outpatient care, some other type of care, perhaps transitional housing is needed, staying for 30 days in a transitional housing facility. But if you're only abstinent for a couple of months, this is kind of the long-term prognosis of that kind of treatment. So if you applied this to any kind of treatment, and I'm just gonna pivot for a second to explain it, and I mean the numbers speak for themselves, but if you said, okay, I have a very serious disease like cancer, and I have to make a choice as to what kind of treatment do I want to have. And the choice is something that will give me 86% chance of remission or 12% chance of remission. What type of treatment should I be selecting? You could do the same for heart disease. You could do the same thing for diabetes. You could do the same thing for any serious disease, is that if we are going to get to this type of outcome set, there needs to be a paradigm shift across all of our country, across all of our physicians, across all of a lot of the treatment resources that we have. So I'm going to share some data from the new paradigm programs like the Physician Health Program. This is one, there's a couple of things I want to say in prefacing this, though, before we get into the actual numbers there, which certainly you can read, but when the Physician Health Program model has been around for decades. So the first objection that I think a lot of people had is, well, okay, that's a safety-sensitive position, being a physician, and maybe there's something different with physicians. Maybe they understand the language differently, or maybe they have more resources, or maybe they're have a different education level. So it works for them. That's great. But then it started to translate into other parts of treatment. So again, judges and lawyers, same objection started to come up. I know then even about 5 years ago at a national conference, I heard people debating what it means that now sobriety courts are doing this. So now if a sobriety court is following that same model, you can't say it's the education level. You can't say it's the resource level. And then people started to pivot and say, well, it's just force. I mean, yeah, if you're going to go to jail, then it's just sheer force. We're going to get to that, but I'm going to address with this another objection people say. They say, well, that's only going to work for certain types of addiction. Like maybe it might work for alcohol because, AA generally is abstinence-based, et cetera. So this study, which was in 2016, they reported outcomes on this, is looking at, and the specific question was, what about opioid use disorder specifically? does this data or does this model apply to opioid use disorder? So they looked at alcohol use disorder, they looked at opioid use disorder, and they looked at non-opioid drug use disorders in 3 separate buckets to say what outcomes differences are there. And the conclusion was there was no difference. It worked for the alcohol group, it worked for the opioid group, it worked for the other drugs too. Now, meaning, what do I mean when I say it worked? There was, depending on the cohort, there was 3 different reports there, but 75 to 82% completion rate at 5 years. That's huge. 70 to 80% with no positive urine screens for the 5-year duration of treatment. That is, somebody entered that program and up to 80% never tested positive one time for 5 years. And as Dr. Merlot shared with us just a few months ago, 90% plus are still in recovery after that 5-year treatment. So this study specifically addressed a very specific and pointed issue, that is this generalizable to multiple kinds of addiction disorders, or is this just like a one type of disorder kind of treatment model? And the clear answer here is it's across the board. So then people again said, well, it's not going to work. It's not going to work if you don't have, if you don't have somebody's license, it's not going to work. Or if you're not going to be able to have like judicial force, like somebody can go to jail, it's not going to work. So this study was launched by the Care and Treatment Network in 2012. They reported it in 2016 again. The patient cohort, again, was a mix of alcohol use disorders predominantly, but there was also opioids, cocaine, multiple other types of drug use disorders here. And let me just state this too, this is a private treatment center. They did not have any ability to have somebody go to jail. They did not have any ability to take a license. This was voluntary. 77.6% of patients completed the 1-year program. 76.3% of people who completed the program were abstinent at time of discharge. 75% of participants had all negative urine drug testing. And so this was the first publication to clearly demonstrate that this new paradigm approach works also in private treatment centers. And I would almost say then this means that it's true for alcohol use disorder, it's true for opioid use disorder, it's true for polysubstance use disorder, it's true in safety-sensitive positions. But this is the first data saying it's just kind of true. So at our center, we had a SAMHSA-funded grant that started in 2017 with the use of technology and longitudinal follow-up care. Our data set includes 617 patients over the last 3 years. The structure of this was engaging people with telephonic engagements, continuing to connect with the patient, their family, their outside treatment providers, and having a multidisciplinary kind of team review process. And what we found using some of the elements of the new paradigm program is that 68.4% remained in continuous abstinence for the first 6 months of the program. And again, this is not judicial, not legal, and the data still bears up, and it still is effective, and it still works. So we launched an even more full engagement with some of the data that we were seeing to really do a full spectrum new paradigm program called the Continued Connection Program. Now, we started doing that full launch of something that looks very similar to the Health Professional Recovery Program in July of 2018. So we are still collecting data, but I'm saying, and I can say already, we're seeing people complete a full year of treatment. Some of our patients would mimic exactly the same thing that you see with 0 positive tests for the entirety of that year, but that incorporates longitudinal monitoring, that is daily check-ins. It also incorporates random alcohol and drug testing. It incorporates family sessions when needed to engage families over longer periods of time. Professional services as indicated, that includes therapy, medical, psychiatric follow-up, advanced relapse prevention, and communication on that so that there is a plan and we're following people throughout that entirety of that first year of their recovery. So we still have outcomes that we are planning and are going to be under evaluation. Our Continued Connection program for the grant is still being evaluated, but I do not want to hold some of that data back from being out there because with 68.4% recovery rates in a general private treatment model, this type of data needs to be out there and out there fast. So when we look at new paradigm treatments then, we have to say what approach is actually going to best fit the brain model of healing for addiction. So new paradigm, again, incorporates long-term follow-up, long-term monitoring, family support, and again, time durations of a year and greater. It provides structure that's needed and the high accountability that's needed when the brain is still healing. It's still healing. And support comes to the patient. The patient is not dependent, or the support is not dependent on the patient. Now, this is something that I think is really, really important from what we just talked about. If somebody really has, in the very first part of a recovery treatment plan, known cognitive deficits, and our advice to somebody is simply call your sponsor. We're putting a lot of that support in the hands of somebody that at that moment may not be able to reach out or may have a cognitive impairment preventing some of that early recovery. We have to flip that around to provide support for our patients for a long period of time while they're healing. And you can see from the science, they heal. And the patient that is there with appropriate supports will heal. And you can see from the outcomes, so it's not just something of wishful thinking, the long-term outcomes in new paradigm programs are excellent. And again, the bar, I guess you could say, is 12%. And so what I would say is if the bar of where we stand right now is 12%, we need to go as far in the opposite direction as possible to get as many people in recovery as quickly as possible because it's life-saving. And relapse is incredibly dangerous. And I know that is not unknown to many, many participants here in the room tonight. So, some concluding thoughts here. Addiction is, again, a primary chronic brain disease, but it heals. The addiction brain in early recovery is vulnerable. Probably the best illustration would be a traumatic brain injury. So if somebody has a concussion, are they vulnerable at that time? Yes, they are. We have to think of what we're doing in that kind of way, that if there is an impairment, we need to design around that. Any treatment approach less than 6 months is unlikely to be successful. Why? The brain does not have enough time to heal. By 6 months, there is healing that can certainly promote long-term recovery. By 12 months, there's substantial and measurable brain healing that is very clear. But the only programmatic way and approach of providing the structure that's needed for really long-term, longitudinal care, not just a month, not just 90 days, 5 years, is going to be found in a new paradigm approach. And those outcomes are excellent, and they far surpass any other treatment approach that's out there.